We're going to build on this conversation about resistance in different settings, but we're going to be, this is our last session before the break, we're going to be changing gears a little bit, and we're going to remind ourselves that AMR is not an issue confined to the clinical world. And to help us do this, Dr. Herman Barkema and Ben Caddy are going to be giving a presentation entitled Tackling Antimicrobial Resistance in Humans and Animals. Pardon. Dr. Herman Barkema is a professor in epidemiology of infectious diseases at UCVM with a joint appointment in the Cummings School of Medicine. He also serves as director of CAN-AMR-Net, holds a United Nations University Chair in Infectious Diseases for a Changing Climate, and is a fellow with the Canadian Academy of Health Sciences. Dr. Barkema's extensive research program focuses on prevention and control of infectious diseases in livestock and humans. He is recognized as a global specialist in mastitis, Johne's disease, and AMR. Dr. Barkema has published over 450 scientific manuscripts and holds a Google Scholar H index of 106. Over his distinguished career, he has been integral to securing over $81 million in research funding, as well as supervising over 61 graduate students and postdoctoral fellows. Ben Caddy is a PhD candidate at the University of Calgary, also Dr. Barkema's favorite of his 61 students, I've been told, in the Faculty of Veterinary Medicine. He received his MSc at the University of Calgary, studying the microbiome of dairy and beef cattle infectious diseases. He now focuses on antimicrobial resistance across the One Health continuum, integrating high-throughput sequencing and population modeling approaches to better understand transmission dynamics and source attribution of antimicrobial resistant infections. Please join me in welcoming them to the stage.
Thank you, Patrick. So I'm going to talk about One Health and international. In the yesterday, today, excellent presentations, but really focused on the hospitals. Yeah, and you know, I often get told by physicians that, oh yeah, you guys, veterinarians, animals, you really have a problem, and causing problems in humans. Well, when I started AMR, I didn't know that there was such a thing as hospital-acquired infections. Really? Yeah, and that it plays a big role in it. Yeah, I mean, we really, people working in human health, need to realize that there shouldn't be a thing like hospital-acquired infections. Yeah, it's weird. And that we need to focus still on hand hygiene. Yeah, it's bizarre. Yeah, so I just want to say that as a veterinarian. Yeah, we also have not spoken nearly about international. We think about problems here in Canada, well, then go to other countries in the world, and Ben will show something about that. And, you know, bugs don't stop at borders. They come in all the time, and we really need to put time and help other countries to deal with these problems as well. That will benefit ourselves. America first, Canada first, is not working. Yeah. Good, I get that off my chest now, so good. So, but still, we have problems in animals as well. If you look at the use of antibiotics in animals, it's about 80% of the use of antibiotics is in animals, in livestock particularly. And not as much in companion animals, but particularly in livestock. But you need to also think of weight there. An average cow, you know, used to be 12 times my size 10 years ago. It's now 10 times my size. Yeah, cows really got smaller over those 10 years, I think. Yeah, so. But you need to give a cow a lot more of antibiotics. And we have way more chicken than people. And also, nearly 3 out of the 4 antibiotics that we give to animals are also used in people, and the other way around. And then the environment, I haven't heard anything, except for the speech of the Minister of Health on environment. Yeah? What is the role of water? Of air? So it's a wicked problem. We call this the confusogram. Yeah? And that's a term coming from the Public Health Agency of Canada. There are so many relationships between animals, humans, the environment. And we know that there are connections, but we often don't know how they exactly work. And then economics, important for farmers. The total picture is not known. And antimicrobial use in livestock is also economically motivated. Yeah? We don't use growth promoters in Canada, but in a lot of other countries, growth promoters are still used. And most of the farmers see antimicrobial resistance in humans as a problem of humans, of human health, and don't see the link. And it's difficult to motivate them just with human health, with public health. But it also works for them. And then the transmission route from animals to humans is not known. So we did a study with WHO where we looked at what the effect was if you reduce the use of antimicrobials in animals. Yeah, what effect would that have on antimicrobial resistance? Is there a way out? And yes, we saw with all these studies that we put together, and this is just a subset of it, that there was a reduction in AMR if you stopped or limited the use of antimicrobials in animals. And also, in this figure, and so this is a forest plot where the zero line means there is no difference. You see that in farm workers particularly, if you stop using antimicrobials or limited it, that antimicrobial resistance in these farm workers reduced a lot. Not only in farm workers, also in the consumers. But again, how that works, we don't know. But it gives hope. Yeah? If we reduce the use of antimicrobials, then antimicrobial resistance will decrease. But key to motivating, what we do all is about motivation. Everybody knows that hand hygiene works. Yeah? So why are people not doing it? Yeah? So, and that's the same problems we have in veterinary medicine with reducing the use of antimicrobials. We need to give those farmers a solution that is economically viable, because they need to compete. Our feedlot farmers compete with the US. If we make their operations more expensive, they cannot compete anymore. So there needs to be a good solution for that. And we need to have alternatives. Otherwise, the financial burden becomes really too high. But we need to work together all on this. And get also social scientists involved, people that know about communication. So if we look at reduction in animals, the key to low use of antimicrobials is good husbandry. Yeah? If animals are fed well, are in a clean environment, feel happy, have good welfare, they get way and way less often sick. So it's the same as people. Yeah? So we can prevent the high use of antimicrobials in animals. And if they cannot keep the animals healthy without the prophylactic use of antimicrobials, they need to look in the mirror. Why the heck is that the case? Why can we not do it? So, and we need to work together across the world with a One Health approach. I'm traveling a lot, 200,000 miles last year. My kids call me a bloody hypocrite when I talk about climate change. Yeah? But to really work with countries and with people in those countries to educate them on good husbandry. I'm a dairy guy, so good milking practices, for instance. They can learn from us, and we can also learn from them. But still, many countries, if you look internationally, do not have a national antimicrobial resistance plan. And then, most of the countries that have a plan, they have other things to worry about. You know, when I talk with people in the Ukraine, this is not really the thing they worry about. Or Gaza. Yeah? So we live in a strange world nowadays. But also, we have lots of poverty. When there is a short of protein, they don't worry about that as much. They need to feed, to have animals. And of course we need to train them to keep them better, but... And then, as you will see what Ben presents, the AMR situation is particularly bad in the low and middle income countries. Because they are now going to larger farms. Keeping the animals, and they're under circumstances that they were not used to. And then access to good health care and proper antimicrobials is not good in low and middle income countries. We need to realize that. And work with them without telling them what to do. We need to go there and then listen and getting to know the situation and together work towards solutions. But because of this low and middle income country situation, 30% of the travelers that we get in Canada comes back with resistant gut bacteria and resistant bacteria in the lungs as well. And what are we doing to assist the low and middle income countries? Look south of the border. What is done by the United States? It kills important organizations like WHO. It is so short-sighted because if the problems arise there, the resistance of bacteria, it will come back to the United States and to Canada and to other countries. Very short-sighted. So if you look at countries like, I work with Nigeria, for instance, the drivers are unregulated antibiotic sale. You can buy anywhere on the street, you can buy antibiotics. there are not enough licensed prescribers. There is a very poor awareness of antimicrobial resistance. Hey, they get a fever, okay, let's just take antibiotics. And antibiotics in animals are used without prescription. So this is a picture of a pharmacy in this case it's, sorry Wasim, it's Pakistan, in Lahore. And you know, this is what you see in countries like that. And you can make all kind of beautiful AMR plans, but if there is no willingness or capacity to really not only regulate it, but also monitor it, then that won't change. So the WHO then, if we go back to livestock, it says stop using antibiotics in livestock to prevent disease without diagnosis. Well, you need diagnostic capacity for that, huh? And that is often not possible. So healthy animals should only receive antibiotics if it has been diagnosed in other animals in the same herd. Yeah, nice, but diagnostics. Class 1 and also category 1 and 2 antibiotics should not be used in animals. And I agree, but then we need to have other options available also. So, and even in Canada, we are using a drug like ceftiofur frequently in animals. So it's banned now nearly in Quebec. Quebec gave a very good example to all of us in the rest of Canada on how things should be handled. But it still is used a lot in the rest of Canada. So my concern is that the recommendations of WHO, FAO, whatever, that apply to developed countries are not workable often in the low and middle income countries. And One Health is actually a relatively recent concept. These organizations, they only started working together in the last 5 to 10 years. And then in most countries, government, veterinary organizations, livestock industry, pharma, they are working separately. Well, Canada is a very good example of that. Every province has their own dental association, their own association of pediatricians, their own veterinary association. And when we did we looked at the different organizations that are making antimicrobial stewardship plans in Canada, there were more than 800. Yeah? And they don't work together often. This is one difficult country to get anything done on antimicrobial stewardship just because of the provincial, federal provincial territory structure that we have. Of course, we want Quebec to be separate, and do things different from the others, and but no, but so, and in development countries, pharmaceutical industries are a different beast than they are in developed countries. In the low and middle income countries, they are only interested in sales. Yeah? Here they talk about antimicrobial stewardship. Yeah? And are willing to work together and are great to work with. But if you go to China, and I've been there now 24 times, if you talk with them, then it's very, very different. So they have two faces. So I hope that we as Canada have learned from the pandemic, where we took all the vaccines for ourselves, like in the US also, and didn't send any to developing countries. And guess now, where do the new strains develop? Yeah? I mean, it's a very, also if you think of ourselves, a very short-term thinking. The world is a global village. So, because bugs don't stop at borders. So Canada first is not the way to go. And it's a difficult time with our focus on defense budget and everything, but we really need to think about development aid as well and working together with other countries. So I'm co-chair of the advisory committee of the Public Health Agency of Canada on AMR, and they made a very nice and good version of the Pan-Canadian Action Plan. But one problem with the action plan, it doesn't have any actions. Yeah? So that is the next stage. They need to have enough funding so that people there can work towards a new version of the PCAP, the PCAP 2.0. Just to promote our organization, CAN-AMR-Net, if you as a trainee are not enrolled yet in CAN-AMR-Net, if you're a grad student, postdoc, early career researcher, think about that. Yeah, we have now about 200 trainees involved, and lots of the people here are, and there's lots of activity in CAN-AMR-Net. Also, if you're a PI, think of enrolling your trainees in it. If you want to learn more about it, happy to tell you more about it. We already have 25 different universities involved in it, and work very well together all over Canada in a One Health fashion. So it's capacity building what we do there. Okay, so let's work together. We can work. One Health is just all about collaboration. And the problem is, veterinary students and medical students don't even have one class together at school. Yeah? And so they don't get to know each other. They don't trust each other. Yeah? And that is something that really needs to change. So then also, most AMR plans have actions, or some not even actions, but they don't have targets. When I take the airplane from Calgary to Toronto, I hope that the captain knows where he or she is, knows where he or she has to land, and at what time he or she needs to be there, and develops a flight plan accordingly. Yeah? We don't have that with AMR in Canada. We're coming with all kinds of beautiful actions without real targets. Yeah, that's not very smart. So, because these actions need to be guided by our targets that we have. Because without targets, there's no accountability. If you don't get there after 5 years, you need to know that where you need to go to. And it's also less motivating. So we need them for every commodity. If I talk about livestock commodities, we need them also for, if hospital-acquired infections are a problem, in your hospital, you need targets. Yeah? And then in the time period, and then if that doesn't improve, in your ER or whatever ward that you have the problems, you need to look in the mirror and sit together. Why the heck is this not working? But people are afraid to make targets also because of the accountability, I think. So in One Health, sometimes they need to be regulatory, like we've seen in Quebec. And it really works. And then we need thorough surveillance. The CPARS program that we have is great, but we need more funding for it. So changing gears, we work with WHO. We 2 months ago actually became WHO collaborating center on AMR. So we were asked by WHO to look at what is the prevalent situation in the world if you look at the do systematic reviews with the literature. So we work together with a group in Indonesia that's affiliated with Oxford University, and then we looked at the glass pathogens and what the prevalence is over time. A group that we brought together, it's 32 people from different countries. So it's also a training exercise. Because these are mainly graduate students, residents, postdocs. We will have 6 papers in the Lancet Microbe on it. It will be a series. The first 2 have been accepted already. So it's a great collaboration all over the world. And that will really help these people later on with their career. So, and Ben is a graduate student in that. Wasim, who's sitting there, put your hand up. Wasim is another. So Wasim had a poster on GI. So we work on 6 different syndromes. And Ben will particularly focus on blood system infections. So Ben.
Yep, I got it. Okay, so I'm going to give an overview of what we've done with the WHO for this AMR surveillance system that we've been making from the published literature. I'd promised Herman that I'd bring in animals somehow, so just wait till the end and we'll bring some in there. But why the heck are we doing this? WHO GLASS system, it's a fantastic program for the past 6 years, well, 2017 to 2023, where they have reported data. They have millions of isolates over that year, over 100 countries enrolled. Fantastic program, but being enrolled in GLASS doesn't necessarily mean that countries are submitting data, and I'll show maps to prove that. When you're talking about global AMR surveillance, you can also think of sharing data, privacy concerns, that kind of a thing. But also for WHO GLASS, individual countries are able to submit data like origin of infection, is a hospital-acquired, community-acquired, age, sex, but they're by no means obligated to do that. So it's a really unstructured kind of sampling that they use for that method. And in this GLASS system, there's obvious gaps in low and middle income countries where resources, infrastructure for laboratory capacities might be limited. So here's a map of bloodstream infections for 2022, data that GLASS acquired, and you can see they cover Europe really, really well. High income countries, that's where they get most of their data from. Africa, kind of sporadic, missing the USA entirely, missing China entirely. So okay, there we go. I got the right slide now. So the data available in published literature can help cover some of these gaps, right? Looking through local journals across the globe to get local data from low and middle income countries where we can fill that gap. getting some of that important AMR-specific subgroup data, so hospital-acquired infections, age, sex, those kinds of things. And we can also do some initial analysis, like looking at strain levels, so sequence types, for example, if we want that, genotypes, as well as going back in time. GLASS only has data beginning 2016 or 2017. We can go back as far as the literature will let us do. So our objectives with our surveillance system that we're making from the published literature was to contextualize WHO GLASS and other global surveillance systems from published literature, find out where the gaps are, can we address them, yes or no. Produce our own country and regional level estimates, adjusted for various factors like origin of infection, sex, things like I said before. Analyze trends over time, also forecasting predictions into the future. And then overall, this is just going to be a fantastic resource for clinicians, researchers across the world. So the infectious syndromes that we followed largely align with GLASS: urinary tract infections, bloodstream infections, lower respiratory tract infections, gastrointestinal infections, and central nervous system infections. All pathogens that are relevant for that infectious syndrome, but also antimicrobial combinations that are relevant and treated for that. The only main difference that we have with GLASS here is for bloodstream infections, we included 7 or 8 different Candida species as our kind of emerging pathogen. And I will show results about that. So altogether, across those 5 infectious syndromes, we did a lot of work. I dream about COVID and still, it haunts my nightmares. But altogether, it was almost 35,000 titles and abstracts, 13,000 full texts that we screened, and 4,000 almost reports that we extracted data from. So it was a lot of work, but it was obviously worth it. We ended up with almost 7 million isolates, which does rival GLASS and other global surveillance systems. And we have well over 100 countries that we included. So for the majority of the rest of this talk, I'm going to focus on the bloodstream system infections. I will hint at some of the other things that we looked at, but for the blood system infections, we have almost 1,500 reports included and 1.5 million isolates for the BSIs. So for global coverage, on the left here, it's really blurry on the screen. And on the right, we have WHO GLASSes. Top left here, total studies, and then we have it split up by different pathogens. So we will just compare the total from our systematic review to WHO GLASS. Some main key differences is that we have quite some different countries that we were able to get data from our systematic reviews versus GLASS, namely the USA and China. And the majority of our data comes from the Eastern Mediterranean region, Southeast Asia. Think of places where AMR burden is generally high. That's where our data comes from, which I think is a very strong advantage to our data. We even get better coverage for some of our other syndromes. So this is the map for UTIs. This map is basically full, right? There's not many countries that we've missed. So the published literature is a really, really, really good source of data that has largely been untouched until now. So we were able to produce pooled prevalence estimates across the globe and split up by WHO region. So on the far left, we have global, and then split up by African region of the Americas, European region, and so on, split up by each individual pathogen. This data is all available in the 2025 WHO report that was just published last month. So I will go into data that's not available there, the time trends, which I think everybody is a little bit more interested in, certainly I am. So our data is from 2010, generally until 2022, 2023. And these time trends are for methicillin-resistant Staph aureus, and we can find some really interesting regional differences in the future trends of MRSA, right? So we go to the European region, it is decreasing over time. It kind of makes sense with this whole search and destroy strategy that has been going on, particularly in Northern Europe. But the problem for MRSA lies in the Southeast Asian region. It goes along with what we've seen from the global burden of disease estimates. where MRSA is the pathogen with the highest AMR-associated mortality in that region, and it appears to be only going to be getting worse over time. So we can learn some really good lessons from this kind of work. For emerging pathogens, non-albicans Candida species in BSIs, echinocandins, not really a problem. Pretty much 0 to 2% resistance over time, not really changing. What we see here is for the azole classification of antifungals. In the European region, it is increasing significantly over time, and that's mainly for Candida parapsilosis and Candida glabrata there, highlighted here. Like I said before, we're going in and doing our stratifications for our AMR estimates. This is the advantage of getting our data from the published literature, so we were able to split by high-income country, low-income country, middle-income country, origin of infection, sex, and I'll show trends for that. We talked a lot about Klebsiella pneumonia yesterday, and here is, I think, really strong justification for studying that bug. Carbapenem-resistant Klebsiella pneumonia, significantly, strongly increasing in low and middle income countries since 2010. Low and middle income countries is this blue line, high income countries is this red line. Talk about the international impacts of importing AMR from low and middle income countries is something that we should worry about, right? I talked to a medical microbiologist at the University of Calgary to try and justify this, because I'm not a clinician. He's like, that's bad, 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 bad. How many bads did he say? Can't remember. So then moving on to E. coli, like I said, in the top row we have the socioeconomic split, and then adults versus children in the middle row, and on the bottom, origin infection, community-acquired versus hospital-acquired. We were able to stratify by tons of different variables, our time trends analysis. So we have lots and lots and lots and lots and lots of figures that look like this. The manuscript that I'm writing for the bloodstream infections has 300, 350 pages of supplemental material just by itself, which is just crazy, and it's taken me a long time. So great. Oh, so we've made it to my kind of, I will transition to the animal sides of things slide, so I'm excited. Some interesting thing that we find for E. coli, for third generation cephalosporin resistance, is that relatively stable for hospital-acquired infections, but for community-acquired infections has been steadily increasing for the past 15 years. You look in the literature and you kind of look for some reasons why this is happening. Follows what we've known for ST131, that's that community-acquired expect pathogen that's kind of been globally dominant over the past 20 years or so. And this is where I want to bring in the importance of veterinary AMR, because we did a review, myself, Sabina Fisher, we roped in an infection prevention control nurse up in Edmonton to help us out on this one. And we found that there was extensive sharing of expect ESBL producing E. coli and other AMR pathogens between pets and their owners. And we published that in clinical microbiology reviews. And one of the main figures and one of the main analysis we did in this paper was to look at the relative proportion of these ESBL producing XPEC, the proportion of those STs in humans, and in the proportion in their pets. So here we see in this burgundy color that I've highlighted, look in the European region, ST131 is the most prevalent generally across the globe in humans, but it's right up there with companion animals too. And I know some of you out there that are a little bit more genome savvy be like, well, STs, yeah, they're great, but there's a lot of variability beneath sequence type. But not so much for this. So I'm borrowing this figure from Kidsley et al. They did this analysis out of Australia in 2010, where they did core genome phylogeny of ST131 XPEC ESBL producing E. coli, sourced from human clinical infections, and then canine clinical infections. All of these in black are the human isolates, and the pink are in the canine isolates. I don't see any clusters there. I don't think you either. This is indicative that they're genetically basically identical, the companion animal isolates and the human isolates. So rapid spillover constantly of these strains, which I think is really important. And it brings me back to an anecdote that I wanted to say. I remember when we were writing this manuscript, I remember reading a paper, a case study, that followed a family for 5 years, and a strain of E. coli, I think it was ST167, it was multi-drug resistant. They sampled the family members and their pet dog constantly, I think, for those 5 years. And they found that same strain popping back and forth, causing UTIs, and the family ultimately ended up with cystitis and the dog. So causing clinical infection in both species, because usually we talk, yeah, sure, the AMR is hopping from us to the other, but it's strictly colonization and it's transient. Not necessarily, right? So something to be worried about here. Last thing I'm going to talk about on the veterinary side of things, we also found carbapenem resistance in companion animals across the world. Also in a turtle. I don't know the story behind that one, but I would like to know. And you think carbapenem resistance, we're not giving pets carbapenems. And not necessarily. Generally, carbapenems are not approved for animal use across the world, but not approved does not mean banned. And in the case of the United States, in very rare circumstances of multi-drug resistant infections, they can give off-label carbapenem treatments to companion animals. Not to food-producing animals, but companion animals, yes. The thing is, they're not approved for veterinary use. So you can't get it from a veterinary drug distributor. So you have to get it from somewhere else, a human distributor or whatever. And in veterinary medicine, we rely a lot on antimicrobial sales data for our antimicrobial use surveillance. If it's not in the veterinary drug distributor's sales data, we can't track the use of carbapenem. So it's really hard to even study how much carbapenems we are using in companion animals. It's just something interesting to think about. And, we think, we kind of got a good idea on what's going on in the AMR space, but there's still lots of things we do and improvements we can make. One last thing before I'll hand over back to Herman is that all of the data that we were producing for our surveillance, for our WHO systematic reviews will be publicly available on a dashboard that Mohamed Jokar and Diego Nobrega are producing. Here is a nice little sneak peek of what it will look like. Basically, each individual report, where that data came from, down to the exact hospital, will be available, and with quality assessment and all of the data we extracted from that paper. So it'll be a really good resource for everybody. So I'll give it back to Herman.
So just some take-home messages. So use of antimicrobials in different sectors cannot be thought of separate actions. And also AMR in different sectors cannot be seen separately. How often do most of you are human clinicians think of the dog or the cat or the guinea pigs in a household that may be a source of infection? So we need a One Health approach. We need to work together on these things. And infection prevention and control is a very important one. Not only in human medicine, also in veterinary medicine. Every infection that doesn't occur doesn't have to be treated. And we need political will. So I sometimes hope that a famous hockey player will get a resistant infection, and then of course cures, because we want him to speak on it, but we need people that talk about it. We don't have enough advocates for antimicrobial resistance. So, and then with what Ben showed, and that's only a very small part of what we are publishing and doing, peer-reviewed literature is a very, very good source. And we can use it for global surveillance. the prevalence of AMR community-acquired infections is also rising. Yeah? So we need to look at the households. Carbapenem resistance is rising globally, and it really becomes dire, particularly in the low and middle income countries. So we need to integrate AMR data. You don't know how difficult it is to bring veterinary AMR data and human AMR data together in Canada. It is nearly impossible to get the data in one computer to look at. Just a plug for the conference that we will have. We had one in March last year. Great conference. We'll have one in March again in Calgary, with great support of Biomilieu as well. Yeah? So look it up, and if you have any questions about that, feel free to contact us. And remember all the time, and this is not only for AMR, it's also for biodiversity, also for climate change. Yeah? A boat with many holes, where we only plug one hole, let's say human health, yeah, will still sink. Yeah? So we need to work together on this. Keep that picture in mind. Yeah? And I've learned that human doctors are great to talk with and to work with. Now, the same is the case with veterinarians, with pharmacists, with dentists. It's a lot of fun when you talk together and you come to real solutions. That's what I had, Patrick.